We'll give folks about 1 minute, I think, Steve, in order to gather into the room.
Correct.
And then we'll start. So for those that are joining right now, welcome to ICER's public meeting for digital health technologies as an adjunct to medication-assisted therapy for opioid use disorder. We'll start in about 1 minute. Thank you. So greetings from many cities across not just the Midwest, but all over the country to ICER's public meeting on digital health technologies as an adjunct to medication-assisted therapy for opioid use disorder. My name is Dr. Eric Arbrecht. I'm a professor at St. Louis University's School of Medicine and our College for Public Health and Social Justice. Thrilled to be helping Steve and the ICER team guide this meeting with an amazing panel of colleagues from around the Midwest and other parts of the country who are joining us today to be part of what will be a wonderful dialogue and a lot of learning about this particular topic. So it is customary when we begin each one of these meetings that we ask for our CEPAC members to introduce themselves and also declare any potential conflicts of interest on this particular topic. So as I said, my name is Eric Arbrecht. I have no conflicts of interest to disclose as it pertains to this topic. I'm going to ask our CEPAC members to use a technique I sometimes do with students and residents in a format like this to call on the next person. So I'm going to start with Stuart. And then if Stuart, once he's introduced himself, can call on the next person, it seems to make sure the flow goes better. I noticed in Zoom, the arrangement of my windows does not look like the arrangement of other people's. So if we can try that, I would be most grateful. So Stuart, just a quick introduction of yourself and any conflicts and any declaration of conflict of interest.
Good morning. I'm Stuart Winston. I'm a cardiologist, cardiac electrophysiologist, clinically retired and currently in charge of patient experience training and provider coaching at a large multi-specialty group based out of Ann Arbor, Michigan. I have no conflicts of interest to report. I'll introduce Greg Kerfman next.
Thank you, Stuart. My name is Greg Kerfman. I'm a deputy editor at JAMA, the Journal of the American Medical Association, and I have no conflicts of interest. Are you there, Tim?
Greg cut out there. I think Greg cut out. I'm gonna suggest, I think the audio cut out for Greg, so I'm gonna go to Timothy, if that's okay, Tim.
Hi, Tim Wilt. Yeah, hi. This is Timothy Wilt. I'm a general internist, health services researcher at the Minneapolis VA healthcare system and the University of Minnesota. I have no conflicts of interest, but I have technical limitations and cannot see who I'm supposed to hand it off to. So Eric, I'm going to let you make that call.
Not a problem. We're going to go to Angela Brown, who I believe is her first public CEPAC meeting. So welcome, Angela. Please proceed.
Thank you, Eric. Good morning, everyone. My name is Angela Brown, and I am the Chief Executive Officer for the St. Louis Regional Health Commission, and I do not have any conflicts of interest to report. And I will pass it off to, I see Elbert.
Thank you, Angela. I'm Albert Huang. I'm a general internist, professor of medicine, and director of the Center for Chronic Disease Research and Policy at the University of Chicago. I have no conflicts of interest, and I'll pass it on to Jean Ryer.
Hi, everyone. Good morning. I'm Jean Ryer. I'm the director of the New Hampshire Citizens Health Initiative, and I direct the work on delivery system and payment reform at the University of New Hampshire Institute for Health Policy and Practice. And I'm going to pass it on to Greg Lowe.
Good morning, I'm Greg Lowe. I'm the director of the Mass General Physicians Organization's Quality and Utilization Program. I don't have any conflicts, and I will pass who is left. Tim McBride.
Thanks, Greg. I'm Tim McBride. I'm the Bernard Becker Professor at the Brown School at Washington University in St. Louis, and I have no conflicts of interest to declare related to this meeting, and I will pass it to Stacy. Good morning, Stacy.
Okay. Hi, everybody. I'm Stacy Ducensina. I'm an associate professor of health policy at Vanderbilt. I have no conflict of interest to disclose for this meeting, and I'm going to pass it to Jill Johnson.
Thanks, Stacy. My name is Jill Johnson, and I'm a clinical pharmacist at the College of Pharmacy. I'm also a professor out of the University of Arkansas for Medical Sciences in Little Rock, and I have no conflicts of interest regarding this topic. I will pass it to Chris Jones.
Hi, folks. I'm Chris Jones, Chief Ventures Investment Officer for the University of Vermont Health Network Ventures exposure. So I manage that financial aspect of our hospital system. I do have conflicts that I think are noteworthy of disclosure. One is that we made an institutional investment into an opiate testing facility called Aspenti Health. And another is that I co-founded a company called Truster, which has Sanofi as a scaling customer. However, I don't think that those conflicts are anything more than an alignment of interest in trying to treat opiate use disorder. So those are my conflicts.
Would you like to choose someone next, Chris?
Yes. I just wanted to also add that I'm a voluntary associate professor at the University of Maryland School of Pharmacy.
Oh,
and let's turn it over to John Campbell.
Hi, everyone. I'm not a part of the panel today. I'm ICER employee, Senior Vice President for Health Economics at ICER.
Sorry, John.
No problem.
How about Don Casey? Don?
Sure, Don Casey. I'm a general internist and on faculties at Rush University in Chicago, Jefferson College of Population Health in Philadelphia, and in University of Minnesota Institute for Healthcare Informatics. I'm also president of the American College of Medical Quality. I have no conflicts of interest or any relevant relationships with industry to disclose. And I'm not sure who's next. Sorry.
Maybe I'll help. I'm trying to keep.
So Megan Golden, I think, is
Thank you.
Final.
Thanks, Stephen, for helping.
Megan.
Hi, I'm Megan Golden. I'm the co-founder and co-director of the nonprofit Mission Cure. We're a patient advocacy group, and we're dedicated to finding a cure and improving the lives of people with chronic pancreatitis, a painful disease for which opioids are part of the standard of care. Oh, and I have no conflicts. Thank you.
Thank you very much. I'm trying to check people off.
That's it, Eric.
That's it. I was like, I think we've got it. Okay. Thank you for participating in that round robin exercise. Really appreciate that. Steve, I think I'll pass the baton to you to introduce the the first subject for today. Thanks.
Thank you, Eric. And thanks to all of you who are participating in this meeting as part of the Midwest CEPAC, and to those of you who are watching in part of the Zoom meeting. So I just want to start off with a brief introduction on why we're here today and the methods that are being used to talk about value as we kind of move through the course of the day. I mean, one reason that we are here today is obviously because patients around the country, individuals around the country, and families around this country continue to really suffer from the opioid crisis. Here's a quote from one patient in recovery who said that people who don't have an addiction do not understand what it is like to feel scared and vulnerable. I want to be better and stay better. If you don't suffer from addiction, you may not figure out what helps patients like me to not go back and back and back to expensive rehab. So ICER and our independent appraisal committees have dedicated ourselves to looking at a variety of different approaches to help with the opioid crisis in this country. And today's meeting is another opportunity to return to many of the needs that are continuing to be unmet for patients and their families, both in the health system and outside of it, to try to deal with this very complicated problem. So one of the other reasons that we take this on is because we do look at emerging treatments. And the day that these types of treatments, whether they're drugs or other kinds of interventions, are approved by the FDA or brought into practice in different ways, one of the things that happens is a celebration, because we are in desperate need of additional kind of helpful approaches for the wide diversity of patients who need help. And so along with that kind of celebration, it also includes a celebration of the investments and the effort over years of companies and clinical researchers and others. The other things that happen to patients and others in our healthcare system whenever anything new is introduced into our system is that, first off, for patients who are trying to get access to new interventions, there are questions about coverage. Is it going to be covered? How will it be covered? What criteria will be used? How much will the patient have to pay out of pocket? Is it going to be so much that it becomes a barrier to access? And we also have to remember that there are others in the healthcare system, and people will always debate how much of a system we have in this country. But if we think broadly, one of the reasons that we're here today is because it's hard not to remember that we really do need to think about other people around our country who are part of our healthcare system and what happens to them, in particular when we introduce interventions that will cost more money. Over time, this has an impact on people who are at the margins of being able to afford health insurance. So these are three case examples that were in a newspaper article. The first gentleman, Gustavo Bendick, is a physician's assistant in Texas, and he and his wife are at that income level where they don't qualify for subsidies on the Affordable Care Act state exchanges, and they found their health insurance premiums going up so much that they felt that they had to do without. And so the article describes their anxiety and their concern about not having health insurance and the stress that that puts them under. Similarly, the Whitmans was an example of a family that includes young children who for more than 4 years had gone without insurance because they felt like they could not afford it. During that time, their kids had had injuries. They were worried that they weren't taking good enough care of the kids, couldn't take them to the emergency room. And so they too expressed the kind of distress that they were experiencing because health insurance had become unaffordable for them. And Luke Breen is an employer, a small business employer, who has seen the effects of his inability to afford to provide health insurance for his employees, how it's affected his colleagues, some of whom have had to leave his employment to try to find health insurance, and others who again live with that daily stress of not being able to have or afford insurance. So I mention these people because what we're going to be doing is talking a lot about treatments, and it's obviously a large number of people in this country, but we can think of it sometimes as an individual clinician would, as the patient or their family that we have in the office. And we want to be able to attend to their needs and focus on them and provide the best available care for them. But we have to remember that in some ways invisible, but always around us are other families, other people who also have needs, who also are trying to afford health insurance. And we want to create a system in which all of this can be held in appropriate balance. It means that we can attend to the patient in front of us. We can offer them and provide them the best available care, but we can do so in a way that is affordable and that matches the payment with the benefits to them in a way that we can keep that health insurance affordable for all. So this is part of the kind of broader goal that we have that drives why we meet to talk about evidence, about cost, about value, and about some of the hard choices around how we continue to innovate and provide incentives for that innovation and do so in a way that is cognizant of the potential harm we can do as healthcare costs continue to rise. So you've met the members of the Midwest Comparative Effectiveness Public Advisory Council. Let me tell you briefly about ICER, which serves as the convening body and the secretariat for the academic review that is done to support the discussion. For us, our sources of funding is maintained in an updated pie chart on our website. You can see that the lion's share comes from nonprofit foundations, within which the biggest single contributors from the Laura and John Arnold Foundation. There are several other nonprofit foundations that we get funding from. We use that money for our research and for these meetings. We do have a separate policy summit program that we run with health plans and provider groups and with life science manufacturers. That money goes to that program and is not used to support the research that we do. So the ICER report itself, which again is kind of the backbone of the evidence that will be discussed today, starts out with what we call scoping. And it's when we turn to patient groups, to clinical experts, to the manufacturers and a wide variety of other stakeholders and really go deep with them to help get from their perspective what is important, what matters to patients and families, what are the questions on the table that we need to really focus on. And we start with them kind of providing our North Star. And then we head off and the internal staff at ICER do an evidence review. We sometimes try to gather new evidence working with patient groups and others. And simultaneously, we're building a cost effectiveness model that helps us look at the long-term value for money. This process goes through several rounds of public comment and revision. And we were fortunate to have as expert reviewers for this report, Dr. Scott Steiger, Jake Nichols, Sean Murphy, and Danielle Torino, a variety of clinical experts and people who are working with patients in recovery and understanding their needs. So with all that being said, the evidence itself in our report and the other information is structured in a way that is meant to inform the deliberation that will happen today, including the votes. So what that looks like, picture, if you will, in a kind of conceptualization, is that we do want to make clear that we think that everybody shares a common goal of a system that can provide fair pricing that is linked to fair access and can support it and future innovation. And to get there, we think that decision makers really need to think about two broad concepts. One is the long-term value for money of interventions in the health system, and the other is the short-term affordability, which can sometimes be in conflict with the long-term value if there's a very, very large patient group that needs to be treated in the short term. But we spend most of our time in these meetings talking about the long-term value for money, and it itself is a composite structure. So here's our report is laid out in a way to support the discussion because there are at 5, if you will, buckets or components of long-term value for money. If we start at the bottom, at the foundation, we want to know if interventions can help us live longer. Do they provide health benefits by extending our lives? Another kind of health benefit is that it may not extend our life, or it can, but it can also help us return function, help our muscles work better, our minds work better, our hearts work better, and or it could provide fewer side effects than other treatments that do the same. We have to look at the total cost overall of interventions, not just the spend here and now today, but does it prevent hospitalizations or emergency room visits or other ways that we could get cost offsets from improved health? Above that, and we'll talk a fair amount about this as well, there are elements that we call benefits beyond health, things that could be very important to patients and their families or to the health system that don't often get measured in clinical trials or are difficult to capture fully in a cost effectiveness model. And then also in some ways, not just at the top, but infusing all of these different layers are values, whether we have special ethical, social values that lend priority to certain types of interventions given the degree of severity or the type of the patient population that is in need. So as we look at these 5 areas of long-term value for money, the real question first is how much extra should we pay for the better health we get? And that's a part of what we'll hear today in the description of the clinical effectiveness evidence and the cost effectiveness evidence. But then again, we have these additional components that are harder to measure, but can be important. And so the way that we do incorporate those in the report and in our broader discussion of value is to start with the bottom set. And I'll move to a slide that will show that bottom set can be used to come up with a threshold price that could reach an added health benefit as measured by a summary measure like the quality adjusted life year or the equal value of a life year gained. And so we can start with this idea that at what, how much should we be willing to pay for added health? And that's a hard question, but if we remember that the goal is to be able to recognize the added health for the patient in front of us, but maintain an affordable healthcare system, good research has been pointing more and more at the idea that to reach that balance, we need to view the threshold around $100,000 per additional quality adjusted life year. So what are we going to do with the benefits beyond health and these special priorities? Well, one very kind of logical way would be to say if that's the upper threshold, then we should start with pricing somewhere lower than that to that threshold. And that's the price that we would link to added health. But then again, we would want to factor in these benefits beyond health and special priorities to figure out how to move within that spectrum of pricing to align with the value. Just to be clear, in ICER's reports, we have tilted, if you will, this consideration upward. And this is partly for historical reasons of consideration around the thresholds in the United States, but it's also to incorporate the idea that we're certainly want to be cognizant of this idea of what the right threshold should be, but we want to provide some additional room to consider these other factors that again can be very important to patients and to society itself. So that's the way that the structure of the report is laid out largely, and it's much the way that the discussion today will ensue. So as we move forward, let's remember that this is our goal. It's to keep everything in balance. It's to recognize the patient and the need in front of us, and to do so in a way that as we all come together, we can remember those who are not in the room as well. The agenda today will move rapidly into a presentation of the clinical evidence, and then we'll follow with the presentation of the economic model, public comments and discussion. We will have a break, and then we'll come back for further deliberation and voting on Midwestern time. This is East Coast time, I believe. So in the Midwest, it will be closer to a normal lunchtime, followed by the roundtable with experts from the payer community, from the manufacturers, from the patient community, and we will wrestle with how to translate the evidence into coverage, pricing, and other aspects of healthcare implementation. We'll have final reflections from the Midwest CEPAC members, and we'll be closing by 3 p.m. All right, so with that, I'm going to, I'm sorry, I should briefly mention, and we have not introduced our clinical and patient experts, but they play a very important role throughout the day. They are as resources to the Midwest CEPAC. If questions should come up, they will certainly have an opportunity to also chime in different ways. But just briefly, we have Dr. Miriam Kamarami, who's a medical director at the Graken Center for Addiction at Boston Medical Center and Boston University. We show their conflicts of interest here as well as in the report. Scott Steiger, who I mentioned before, who's Associate Clinical Professor of Medicine and Psychiatry at UCSF. Jake Nichols, who's President and Chief Executive Officer of Professional Recovery Associates. And Kevin Roy, who's the Chief Public Policy Officer at Shatterproof. We'll allow them to introduce themselves later when we get close to the policy roundtable time. But again, just to remind the Midwest CEPAC that these folks are available for comment, for perspective throughout the day's discussion. So with that, I will now hand it over to Dr. Jeff Tice, who is going to present the clinical evidence. Jeff, over to you.
Sorry, I was on mute, speaking away. So again, thank you, Steve, and good morning, everyone. Really appreciate everyone taking time out of their busy lives to join us here and engage in the discussion. I'm going to present the clinical evidence. Next slide.
Jeff, can you hear me?
I can.
Yeah, I'm sorry. We're getting a little bit of feedback. If you can try to hold the microphone just a little bit closer to your mouth. I'm not sure it's coming. I don't think it's coming through your headset. We can hear you, but it's just a little bit sketchy. So thought I would notice now if you can.
Boy, this is what I've done for a long time. I haven't had any problems before. Is it better now? It looks like Megan shaking her head yes.
We're hearing you okay. There's some background noise, but why don't you go ahead and just, if you speak up, I think it'll make it easier for folks to hear you.
Okay, I'm sorry. I've not had this problem before and I haven't changed the setup. So again, thanks. And I'm going to present the clinical evidence. Next slide, please. So a couple of key collaborators who did the heavy lifting in abstracting data from finding the trials, abstracting data, Nguyen Flush and Kanya Shah, and myself included. We have no conflicts of interest to report. Next slide, please. So as Steve laid out, opioid use disorder is a terrible problem in the US. We're all aware of that. And the deaths continue to increase during the pandemic. In San Francisco, where I'm based, they doubled last year compared to the prior year, and they're even higher this year. So it continues to be a terrible problem, a growing problem. And the social and economic consequences are enormous. The estimates financially for the 4 years from 2015 to 2018 were in $2.4 trillion in the US alone. Medication-assisted therapy is the most effective treatment, but fewer than half of patients remain on MAT for 6 months or longer. And there are a number of psychosocial interventions that have been shown in some studies to increase retention, and many of them are incorporated in the digital apps, so that's why I highlight this here. Next slide, please. The impact on patients is enormous. We hear from them in particular that disrupted relationships with family and friends are particularly important. They lose jobs and housing. Social stigma is a recurrent theme, and one of the hopes is that apps will help to reduce some of the risk for social stigma. And of course, there are health impacts, infections like HIV and Hep C, but also intermittent adherence to treatment for their other chronic diseases, taking their medications for hypertension, diabetes, and so on. And that leads to other health impacts beyond the immediate consequences of using opioids. Next slide, please. So the scope of our review, we focused on adults with opioid use disorder. We did not exclude patients who had other comorbidities, including other substance use disorders, but they had to have opioid use disorder as one of their primary diagnoses. The intervention is standard medication-assisted therapy, primarily buprenorphine or methadone, with digital health technologies added to that. The comparator was medication-assisted therapy alone. And the primary outcomes were retention in MAT programs and abstinence from illicit drug use. we heard from the experts that opioid use disorder is somewhat different from other treatment for the goals of treatment for opioid use disorder differ somewhat from other substance use disorders because it's not primarily focused on abstinence. It's really focused on continued engagement with the program and taking their medication-assisted therapy. And finally, we heard over and over again that remaining in programs providing MAT for a year or two is really necessary to translate into the improved outcomes that I highlighted before of reestablishing relationships with family and friends, getting jobs, and so on. So ideally, the time frame would be at least 1 to 2 years when we're looking at outcomes. Next slide, please. So what are some of these psychosocial interventions and what's the evidence behind them? So cognitive behavioral therapy has a long history in behavior change in general and has been tailored in a number of different programs to address opioid use disorder. Another widely used, or at least widely studied intervention is contingency management. I'll talk about it a little bit more, but essentially patients receive rewards for doing behaviors that are desired, coming in for appointments, completing CBT sessions, providing urines that are free from illicit drugs. There was a recent AHRQ review of all of the psychosocial interventions for substance use disorder in general. And the two conclusions that I think are relevant for our perspective on time today is that these interventions were associated with an increased likelihood of abstinence versus control conditions at 3 to 4 months, but there was no difference versus controls on drug use days or severity of disease at a longer follow-up, so 6 to 12 months. But again, that focused on all substance use disorders. Next slide, please. So what are the technologies we're going to talk about today? So Reset-O is an unusual one, and really what spurred us to take on this topic because the FDA approved this digital therapeutic. You know, a digital therapeutic is a more specific designation for digital therapies. It requires an intention to diagnose or treat a medical condition, and it requires FDA approval. And in this case, in order to access the app, a physician or healthcare provider needs to write a prescription for it. That's not true for the other two apps, Connections and Dynamic Care. All three provide CBT in some form. The Reset-O and Dynamic Care also incorporate contingency management. And the Connections app, as the name implies, also is fundamentally built on peer support. Next slide, please. So what do we learn from talking to patients? The primary theme was that patients are unique. There's a lot of difference from variation from patient to patient. A 20-year-old is different from a 60-year-old with opioid use disorder. Those who use the drugs through an intravenous route have different issues than those who solely use it through an oral route. Many have received, gone through different treatment programs in the past. Others, it's their first program. They suffer from other substance use disorders and mental health issues. There was a publication in JAMA Open in the last few weeks looking at more than 40,000 patients, and more than 40% suffered from a comorbid psychiatric diagnosis. And of course, some have family support, some have none, some are housed, some marginally, and some not at all. So one size does not fit all was one of the important themes, and that different forms of MAT, different provider types, so some require or benefit more from addiction specialists, some do better receiving MAT through their primary care physician. And finally, different psychosocial therapies may have differential benefits depending on the background of the patient. So, and the outcome that matters is, quote, getting their life back, which means reconnecting with families and friends, becoming housed again, starting to work again, and really a restoration of trust with the larger community. Next slide, please. So with that background, I'll turn to the evidence we have. Next slide, please. So randomized trials, unfortunately, there are no randomized trials for any of these therapies in the form that they're delivered. So there are no randomized trials of the apps themselves. In part because of the FDA approval, we're gonna talk about the background evidence behind Reset-O. It's primarily from something called the Therapeutic Education System, which implemented a form of CBT through the web. So it was computer-based and has been studied, and I'll review the evidence base there. For connections, again, no randomized trials, but it's based on two approaches that have been funded through multiple clinical trials funded by the NIH and SAMHSA, called HS and CBT for CBT. But again, there are no randomized trials of that combination together in the app form. And finally, dynamic care, again, no randomized trials, one observational trial, which I'm not going to discuss today, in part because the evidence base was weak enough for connections and dynamic care that we did not then translate that into the economic model. So for today's presentation, I'm going to focus on Reset-O, but there are the data supporting connections and dynamic care are in the report itself. Next slide, please. So here are the 4 clinical trials of the therapeutic education system, and I'll highlight the first one, Christensen et al. 2014. This is the clinical trial that formed the basis of the FDA submission for Reset-O, and it compares computerized CBT delivered in the office plus contingency management added to buprenorphine. And in this trial, it compared it to contingency management alone plus buprenorphine. It was a 12-week trial, and probably the most important outcome is that at the end of 12 weeks, retention was higher in the arm that incorporated the computerized CBT, 80% versus 64% in the control group. Bickle et al. Used the same computerized CBT system, compared it to therapy-delivered CBT, but also had MAT alone arm buprenorphine, and it was a 23-week follow-up, and you see the retention was lower than in Christensen, as would be expected with a greater time, and that there was some heterogeneity across the 3 arms of the trial. And if I'm going to switch down to the last one, Marsh et al., it has, they again use the same therapeutic education system, the same computerized CBT, but compared it to methadone as the MAT. And this trial had a 1-year follow-up, 80 patients in each arm, and you see that retention was identical when you got out to 1 year in that trial. So that gives you a flavor of the overall evidence base for the TES. I'm now going to turn to a little more detail on Christensen et al. Because that's been the focus. So this is a single site trial. It was unblinded, so there was no sham intervention, no sham computer education program that patients did, so they really knew whether they actually got the active treatment or not. And there were some important baseline imbalances between the treatment groups, which raised concerns about allocation blinding, so whether there were issues in selection bias in the development trial. The interventions also fundamentally are different from those in Reset-O. The contingency management piece in Christensen et al. Was based on consecutive negative urines for illicit drugs. Those always led to higher rewards. So if you had delivered the urine, and they asked for urine samples 3 times a week, so a pretty intense program. Every time you got a negative urine, you got a reward, a voucher with a certain monetary reward, and consecutive negative urines led to higher rewards, and that was consistent. And Reset-O, their form of contingency management, is intermittent, meaning sometimes you just got a thumbs up, great job, but sometimes you got a payout, and consecutive, if you had consecutive positive behaviors, you had a higher likelihood of getting a payout and a higher likelihood of having a higher payout, but you weren't guaranteed a payout. So there are 2 different styles of contingency management, and with the one in Reset-O, the average payout per patient was less than $300, where it was almost $1,000 in Christensen at all. And then the CBT modules themselves were delivered in a different way. In Christensen, the patients had to do them in the clinic at a computer, whereas in Reset-O, one of the potential advantages is that they can be done out of the clinic on a smartphone. Of course, that will certainly appeal to some patients. On the other hand, if patients have no home, it may be much more challenging for them to find a quiet place to actually work through these. So either one could be an advantage depending on the individual patient. Next slide, please. The primary outcome in the randomized trial was days of continuous abstinence. And while there was a trend towards benefit with TES, 59 days versus 55 days, it was not significant. So the methodologists know here that our p-values are dependent on us having a primary outcome, and that's really the only statistical outcome that we should pay attention to in trials. Any other outcomes are hypothesis generating because they weren't defined as this is what we're looking at, and the whole statistical machinery depends on having a primary outcome and focusing on that. So secondary outcomes, one was retention and treatment, and I already highlighted that was significant, p-value 0.02, and a clinically important difference, 80% versus 64%. And they reported the odds ratio, which is a little misleading in something when the outcome is somewhat higher. Certainly 80% is not 2.3 times 64%. And then just this month, there's a new publication that did a complicated general estimizing equation analysis of the likelihood of a patient having a negative drug test at least once during the final 4 weeks of the trial. It was significant at a p-value of 0.03, so 76% versus 61%. But that doesn't mean that patients were totally abstinent during that last 4 weeks. It just was the probability of being abstinent at least once during that 4-week period. Not the outcome that we were thinking about going into the trial. We thought an extended period of abstinence would be the more important outcome, and that's not been reported. Next slide, please. So also this month, so after the draft report went out, there were 2 other publications of some real world evidence. One looked at a little over 3,000 patients who had redeemed Reset-O, so actually called the company, got the code to unlock the app, and completed at least one module. So they looked at abstinence during the last 4 weeks. Unfortunately, there were no data for almost 900 patients, so 28% of patients had no data during the last 4 weeks. But the paper reported that 66% of patients were abstinent during the last 4 weeks. It was a little unclear the methods used for that. Likely it was the same GEE approach, but some of the authors, I think, are on the call today and can probably answer more questions about that. And then finally, probably the most promising data for Reset-O looked at claims data from 351 patients using Reset-O, and they compared, it was a pre-post approach. They looked at claims during the 6 months prior to initiation and claims during the 6 months after. Interestingly, in their table 1, they were only able to capture buprenorphine use in 76, almost 77% of patients during the 6 months prior to initiation. And that number was actually lower in the 6 months after initiation, even though the prescription, I should have said this before, the prescription for Reset-O requires that it be given in the context of buprenorphine MAT. So there were clearly some issues with capturing at least pharmaceutical data for these patients. Hospitalizations went down dramatically from 72 in the pre-period to 27 after, and this represented 29 patients, clearly multiple hospitalizations for some patients, and during the pre-period, and 13 patients in the post-period. And finally, ER visits also went down from 136 to 109, and this represented 84 patients in the pre-period and 38 in the post-period. Next slide, please. So harms, we didn't identify any digital harms from the digital technologies. With Christensen et al., they did, again this month, report on adverse events and serious adverse events in that trial, and there were no differences between the TES arm and the MAT plus contingency management arm. There are theoretical concerns that you have digital information about these patients, and there could be hacks and PHI release, but there's certainly no evidence of that to date. Next slide, please. So the controversies and uncertainties in considering the evidence base, I think the lack of any randomized trial evidence on the efficacy of the apps is the major source of uncertainty. In addition, the primary data for Reset-O comes from a 12-week trial, and really we'd like to see at least medium-term outcomes, so 1 to 2 years, and ideally longer-term outcomes if we're going to see return to work, housing, and so on. And then finally, there's no clinical trial evidence on ER visits, hospitalizations, work, relationship restoration. None have been reported in any of the trials, though we do have this new pre-post real-world data, which suggests benefit. Though I should say, I meant to say, you know, one of the concerns in any pre-post trial like this is that patients with a high number of hospitalizations and ER visits may be just the ones that are targeted for a program looking at Reset-O, and then we may have this phenomenon called regression to the mean, that if you sample a group of people because of a high blood pressure, you measure their blood pressure again 6 months later and it's lower. And that's just a statistical sampling effect. And it's unclear from the publication whether that's a major concern with the reduction in ER visits and hospitalizations in that pre-post study. Next slide, please. So there are a number of potential other benefits and contextual considerations. We've highlighted this several times now. We really don't have long-term follow-up, so there's considerable uncertainty about the benefits. Because of the digital divide, there is some concern that digital health technologies have the potential to increase health disparities rather than reduce them. Most of them are only available in English at this point, so language disparities are an issue, and then facility with smartphone technology may vary, particularly for our older patients, but also for some who've been marginalized for other reasons. And then finally, we have really a tremendous amount of uncertainty about the impact of these technologies on family and caregiver burden and on the return to work. Next slide, please. So we received a number of public comments. One was the new data published in November, 3 new papers, and so we've incorporated all of them. I highlighted some of the data today, and we've added them to the final report. We also received a lot of comments about contingency management, that it's accepted as efficacious in substance use disease, and we agree, but it's been primarily for alcohol and stimulant use disorder. Over the past few decades, it's really been focused on cocaine use, and the effectiveness for opioid use disorder is more mixed in randomized trials and controversial, and it's certainly not standard of care. Not even half of treatment programs incorporate contingency management at this point, so it is not yet standard of care. And then we also received a number of comments about the fact that the randomized trials of the TES do have data beyond 12 weeks, and we noted all of those trials were already described in the report, including MARSH, which I highlighted. The retention at 1 year was identical in the 2 arms in that trial. And finally, Christensen is a single site trial done in 2010. So there were concerns that, you know, at the time of publication, they could have asked at that site, are these patients still coming in for treatment? We could have had 6 month, 12 month, 2 year follow-up, and that's never been reported, which it seems like in a single site treatment center, you could have easily captured that information. And then I haven't gone over this yet, but the basis for the FDA approval of Reset-O was through a mechanism called the 510K approach. And that means if a new intervention is substantially similar to something that's already been approved by the FDA, you can argue that if this is safe, you should just approve it without clear evidence of efficacy. This is primarily used for medical devices. It's been quite controversial. But even so, we did, one NIH researcher highlighted concerns about the evidence base behind Reset, which is a similar app that's focused on other forms of substance use disorder. So that was the other important public comment that I thought I wanted to highlight here today. Next slide, please. So in summary, there are no direct peer-reviewed randomized trial evidence on the efficacy of any of the apps. There are randomized trials supporting the short-term efficacy of some of the psychosocial interventions implemented by these apps, but not them packaged together as an app. We thought that the use of the apps is unlikely to be harmful to patients, but certainly looking forward to more discussion about that. And based on that, we thought that there's moderate certainty that the digital apps are at least comparable to MAT alone because of the lack of harms. And there may be incremental benefits, but a tremendous uncertainty there. Next slide, please. And on the basis of this, using the ICER evidence rating system, we gave all 3 apps a C+, so comparable because of lack of harms, or incremental because of some evidence from the predicate psychosocial interventions that they may be beneficial, but really a tremendous amount of uncertainty. Next slide, please. So with that, if we have time, I'm happy to take a few questions, or we can move on to Dr. Whittington's economic presentation. Steve?
I'd like to take a few questions if we can squeeze them in, Steve. What do you think?
Yes, I think we should. Please go ahead.
Okay, that would be great. You know, you can use your raise hand icon, or you can direct message, you know, use the chat box. But I had one message or one question come in while we were talking. I'm going to pass it to Tim Wilt for just our first question, but others, please raise your hands or let me know. We'll try to organize the chaos of Zoom discussion group. So.
Thanks, Jeff, for the nice presentation, the team working with you. So from what I summarized or gleaned from it, that there were really no outcomes that I would call patient-centered, certainly as you outlined, what the patients really want. I want to get my life back, housing, things like that. And some of your concerns about outcomes such as just retention. I assume that's correct. Okay, and then 2, I'm going to ask if you can just provide a brief summary of the kind of patients enrolled in this, and you're between the lines about how they had to go out to recruit them, and thus the generalizability I think we sort of described in your opening about how these things may vary a lot by type of drug use, other kind of aspects, sex, race, socioeconomic status, et cetera, and, you know, just the interest in doing that app. And then finally, sorry, I'm using 3 questions. I struggle to see how you got to a C+. I mean, you go all over the place saying how there's uncertainty here and there's not good data there, and it's just, and we don't really have anything on harms. I don't think the apps give you like radon to your brain, but you know, there's all sorts of stuff about having to go and use additional technology and things like that. I just think there's complete uncertainty about this. If we hold it to whatever we use for most evidence, we don't have to have a randomized trial. Well, we got to have at least some reasonable observational data. Sorry, I kind of went off on a little roll on that last one. But it seems to flow from what you were saying about the evidence.
Yeah, thanks, Tim. I'll try and address your questions. Yeah, I mean, you know, in truth, my initial assessment was promising but uncertain, and then we had some discussion that required some reasonable probability of harm from the therapy, which is why we changed. But different people will interpret the ICER guidelines differently. But I certainly hear what you're saying, and I appreciate you articulating that. You know, in terms of the consort diagram for the trial was sort of inadequate. They started with consented participants, so we really don't see the full pipeline of recruited participants, and it was at a single site. So again, challenging to generalize from one site where there may be you know, particular interest and expertise in implementing this, and whether that then translates out to other clinic types, or particularly with buprenorphine to primary care practices where many of us are prescribing it. And, you know, many patients would like to receive therapy because they escape the stigma of going to, you know, a treatment center where it's predominantly for people suffering from substance use disorder, which unfortunately is a barrier for some patients. And then finally, the types of patients that were included, I think a little over 10% had alcohol use disorder, around 5% were also using cocaine. I can't remember whether they, I'm now looking to see if they talked about it. Yeah, maybe, I don't think it wasn't clearly described, but you know, 10 to 15% had other psychiatric disorders, which actually is low compared to my reading of the literature on the patient population in general. And about 15% were using an intravenous route of administration, or at least a parenteral route. So I don't know if that gives the kind of context that you were interested in here.
And your gestalt is that these are, that most people use apps or computer kind of stuff. I mean, maybe, I don't know why maybe I'm pejorative thinking about a county hospital or other folks that aren't quite, including somebody my age, not quite so app.
You're breaking up a little bit, Tim, but I think I got your question. I might turn that to our clinical experts. So Drs. Steiger and Kamarami, do you want to comment on the availability, you know, the comfort level of the patients who you treat with, you know, digital health technologies, smartphone applications, and so on?
Sure, I can jump in. For starters, this is Miriam Kamarami. I practice at Boston Medical Center, which is the largest safety net hospital in New England, and I care for a pretty marginalized patient population. I would say that most of the patients who I care for do have phones, and many of them have some kind of smartphone capability. They often lose those phones or have them stolen, et cetera, but quite a high percentage of them have the capacity to use an app on a phone. I think there are concerns about an app like this because of reading level and sort of technical sophistication required, but in terms of just having access to a phone, I do think that the majority of the patients who I serve in this and previous settings have phone access and smartphone access at that.
Do we have any more? Thank you very much, Miriam. Yeah, Megan, would you like to
just a quick somewhat follow up to that is I feel like I'm kind of missing the patient perspective on how they view this app and how they use it in practice, and how kind of the getting away from stigma and convenience, how big of a factor that is. So were we able to hear from patients who have actually used these apps about that type of information?
We tried, but did not get much input from patients who've actually experienced this. I don't know. So we do have at least one patient expert on the panel. Jake, do you want to comment on that?
Yeah, I'm actually happy to comment on that. And again, you know, to be clear, I'm here as a patient representative, but I've also worked in the field of addiction medicine for the past decade or so and worked directly with digital products. And the stigma piece is massive. I don't think I need to tell anybody on this call. You know, we know this. And for some people, it's a low impact way for them to access care without having to worry about stigma. And for many, at least folks that I've interacted with that have utilized digital products, it's kind of their first step into treatment, kind of dipping their toe in the water, if you will. And they're skeptical about it. We know you have a disease that's actually telling you you don't want to engage. For many, or at least the folks that I've engaged with that have utilized these products, it's a very safe first step into it, which kind of breaks down a little bit of that stigma. So yeah, great question, Megan.
Were any of these studies apps alone? Because to get at that point, don't these all still require some kind of therapy or engagement with a professional group, and this is more of an add-on? Would it take that away? I don't know that.
We set that up. I mean, that of course was part of our scoping that we were really looking at them as add-on. I mean, I think our experts I know would agree that the most effective treatment for opioid use disorder is MAT. And yeah, you know, so if this was if this would facilitate getting, if apps would facilitate getting people into MAT, that would be great too. We didn't look for that, so I don't know if there's any evidence to support that. But I think most people feel like you know, we need to get people into MAT and keep them on MAT. And again, we focused on, do these apps help to keep people in MAT for the long term?
Thanks,
Yeah,
Jeff.
my comment is
go ahead.
about that very point on the last bullet of your summary slide. I think it's because of too much economy of language, but it does seem to suggest that just because of the way it's phrased, that MAT is not the preferred treatment, and it would be good to make that a little bit clearer on that slide.
Well, thank you. MAT is the preferred treatment, and then you know, we're just hoping to do better than we do with MAT right now. That's the goal of these apps.
Do we have any more questions from CEPAC members? Yeah, Albert.
Yeah,
and then Christopher. Yeah.
There have been some really good questions about patient-centered outcomes. It seemed like, Jeff, from the main, you know, from the summary, that the most promising outcome was actually retention in care. I wonder if you could talk about what the normal rates of retention in care are. How impressive are the slight increase in retention in care that how important is that?
And again, I think the clinical experts would say it's important. The question is whether it's maintained beyond 12 weeks. And again, the one trial, it wasn't, you know, it used the CBT portion, the computerized CBT, but didn't use contingency management. You saw at 1 year, the rates were down to 38%, which is sort of what I think that's pretty typical for what you see at a year. Yeah, you know, the other I guess piece with that was they used methadone, and most of the data comparing methadone to buprenorphine is that people using methadone do a little bit better in terms of retention, not hugely, but a little bit better than buprenorphine. The real advantage to buprenorphine is that we have more providers in primary care. It sort of increases access, but it's not necessarily better than methadone. So when you're looking at the retention rates in the Marsh trial, if it was buprenorphine, you might have expected those to be a little bit lower. But again, even a 12% increase in retention at 12 weeks is promising, but you'd like to see it out a year or two.
That's great. Thank you, Jeff, for that. We're going to move on to the economic model presentation right now. I know we probably have an abundance of questions, but some of those regarding the evidence you'll see appear in the assumptions that are built into the economic model. So, Dr. Whittington, are you ready to go?
I am. Thanks, Eric. Hi, everyone. I'm Mel Whittington.
Thank you.
I am the Associate Director of Health Economics. Next slide. First, want to acknowledge team members, Dr. John Campbell, Dr. Rick Chapman, Dr. Lorenzo Villa-Zapata, and Nick Mendola have been fantastic collaborators for this part of the review, and none of us, including myself, have any relevant conflicts of interest to report. Next slide. The objective of this part of the review is to estimate the cost effectiveness of digital health technologies as an adjunct to MAT for OUD. So we're living in this world of outpatient OUD, adding on a digital health therapeutic, and then comparing it to this world with only outpatient MAT and no digital health therapeutic. And as Jeff mentioned, we considered all of the interventions that he walked through in our economic model, but data dictated which ones were sufficient enough to be included in our model, and Reset-O was the only digital health technology with data sufficient to be included in the model. And so our primary intervention and comparator for the rest of my talk is Reset-O, again, in addition to outpatient MAT, which is including counseling and pharmacological therapy, as compared to outpatient MAT alone, again, including counseling and pharmacological therapy. Next slide. To briefly walk over the methods, there's much more extensive detail in the report that's on the ICER website. But we have a two-phase decision analytic model, and I'll talk about those two phases on the subsequent slides. The setting is the United States perspective, setting is United States, with our perspective being that of the healthcare system. So focused mostly on direct healthcare costs, we do expand this perspective to a modified societal perspective that we present as a scenario analysis. Our time horizon is 5 years, and we've received quite a bit of comment on that. That is different from the traditional lifetime time horizon that's in the ICER reference case. So I'm going to spend a moment to talk about this. Looking at prior cost effectiveness studies in this area, it's much more common to have a short time horizon, very common around 12 weeks to 26 weeks. And this is because of so much restart and stop in this care setting. But it's worth noting that if we did take this lifetime time horizon, the results would be nearly identical to the 5-year time horizon results report today, and that's because we had convergence in outcomes observed before that 5-year time horizon. So don't worry too much about the time horizon and that it's not a lifetime. We wanted to extend it beyond the time on Reset-O to be able to capture any potential benefits and costs that exist beyond the 12 weeks of Reset-O use, and we are capturing that in the 5-year time horizon. All future costs and outcomes are discounted at a 3% per year rate based on best practices in the field. Our cycle length for phase 2 of the model, which I'll talk about here in just a little bit, was 4 weeks. Our outcomes are total costs, quality adjusted life years, EVLYGs, the equal value of life year gained, and then a clinical outcome of time on MAT as measured by MAT year. Next slide. So again, we have a 2-phase decision analytic model, and this slide shows a schematic for phase 1, which is our upfront decision tree that tracks the patient from starting the treatment through 12 weeks, through the duration of Reset-O. And so we have our population, that's the text on the most left-hand side of this slide, and that's adults with OUD in outpatient treatment with MAT. And then we're living in these two worlds. One, in this world where an individual receives Reset-O in addition to outpatient treatment, and then in a world where they do not receive Reset-O. And we have 5 possible health pathways an individual could occupy. And that's on MAT with illicit use of opioids. These are individuals who have not discontinued MAT treatment, but have not abstained. Second is on MAT without illicit use of opioids. So these are individuals who also have not discontinued, but they have also abstained from opioids. Off MAT with illicit use of opioids is our third possible pathway. These are individuals who have discontinued MAT treatment and continue to illicitly use opioids. M4 is this off MAT without illicit use of opioids health state. This health state is characteristic of persistent abstinence. More detail provided in our final report, and I can absolutely take questions here. But due to the short duration of phase 1 being 12 weeks, no one was able to occupy that pathway for Reset-O. And then the last health state is dead. Worth paying special attention here is the evidence that Dr. Tice just walked us through. Primarily the Christensen study, which was the pivotal trial for Reset-O. That was the primary evidence source that informed the Reset-O efficacy for phase 1. And so we had evidence to suggest that. We define and we measure abstinence in phase 1 based on abstinence days reported in this study. So now let's go into phase 2. If we could progress to the next slide. This is a Markov model. A Markov model, as an economist, we love these. There's so much information presented in this slide. All of the circles define health states that an individual can occupy. These are mutually exclusive and exhaustive. And then the arrows show transitions between these possible pathways. And because I just mentioned the evidence source for phase 1, we don't have evidence from phase 2. This is our time after the use of Reset-O, so after 12 weeks through the end of our time horizon. We don't have evidence here for what happens to a patient who no longer is using Reset-O. And so we had to make assumptions, which I'll walk through on the next slide, but we can do this in decision science as long as we acknowledge these assumptions and we can critically appraise them like we do today. You'll notice the health states, the M1, M2, M3, M4, and then the dead health state are equivalent to what you saw on the decision tree and those pathways that are presented. But here in phase 2, where our cycle length is 4 weeks, we measure abstinence based on this period of continuous abstinence. So to get to a on MAT without illicit use of opioids health state, we need a period of 4 weeks of continuous abstinence. let's go on to the next slide. There's a lot in there, so I'm happy to take questions there at the end. Key model assumptions. The first one is how we are defining abstinence and how we are measuring abstinence in our phase 2, in that period where we don't have evidence to suggest that, and so we're having to make assumptions. And for this, we measure abstinence as individuals with negative urine drug screening tests across all assessment points over the last 4 weeks of reset-O use. Those are the individuals that entered that M2 health state in our Markov model, in that health state of on MAT without illicit use of opioids. And that's because we want to get this period of continuous abstinence. So this metric suggests that. The second bullet, there were no incident cases of abstinence in phase 2. So in the Markov model, there was no arrow from M1 to M2, as you might have noticed. This is really suggesting that there are no new cases of abstinence in phase 2. Again, we don't have evidence after an individual has stopped using reset-O. And so we did not feel comfortable assigning any new cases of abstinence, but we aren't assigning that to standard of care either. And so this isn't an assumption that benefits or harms reset-O. We're assuming it's the same as standard of care. The third assumption here is about MAT discontinuation. So as Dr. Tice mentioned, MAT retention was significantly different at the end of reset-O use, around 80% and 64%. So these individuals are ending reset-O at a different level on MAT. And that's why we wanted to extrapolate this time horizon beyond 12 weeks, because there might be a benefit that goes on past the 12 weeks due to that differential. But we don't have evidence on what discontinuation or no longer using MAT looks like after those 12 weeks. And so we assume that discontinuation occurs at the same over time. However, those in the reset-O arm start at a higher level. They're starting at that around 80%. This is an assumption that favors reset-O. It could be a plausible assumption, and we heard this in public comment, that individuals, once reset-O stops, they could just revert to the exact position that standard of care is. And so that is a plausible assumption. That was not the assumption we made in this analysis. And last, the clinical outcomes for standard of care, we assumed were equivalent to the outcomes from the comparator arm in the reset-O pivotal trial. And if you remember from Dr. Tice's talk, in the reset-O pivotal trial, the Christensen study, the comparator was not standard of care. It did include contingency management. And we heard from numerous stakeholders throughout our review process that standard of care does not include contingency management. And so it left us in a tough position where we had this pivotal trial that was not compared to standard of care. And therefore, we had to make assumptions about what standard of care might have looked like if that was what was done in the study. And we assumed them to be equivalent. Dr. Tice already mentioned the heterogeneity in evidence around the potential benefits and potential harms of contingency management in substance use disorder and opioids. We assumed they were equivalent. Next slide. Our population, adults 18 years and older with opioid use disorder and outpatient MAT. Key population characteristics are displayed on the slide, with mean age and percent female primarily influencing mortality risk and quality of life. The injection drug use is presented. This factors into the cost effectiveness model because we assigned comorbidities that may be associated with injection drug use, such as HIV and hepatitis C virus. And then the employed full-time percent comes into factor in the modified societal perspective scenario analysis. Next slide. These are our key model inputs. Really our big things that are driving the model for reset-O are its benefit on abstinence and retention. And again, we have these two phases of the models. We have different data inputs that influence each phase. So focusing first on abstinence, if we look at phase 1 of the model, this time while using reset-O. The pivotal trial, the Christensen study, did suggest a higher number of total abstinence days in the reset-O arm. And so we assigned that in phase 1. Again, abstinence in phase 1 was measured based on total abstinence days. Now, phase 2, this is this period of continuous abstinence. This is what we didn't have data to suggest for, so we had to make some evidence-based assumptions. Now, given that the pivotal trial, the Christensen study, did not suggest a difference in continuous abstinence between reset-O and the comparator, we assumed the same value between reset-O and standard of care in this phase 2. The exact value was provided to us by Pear Therapeutics and is data on file, and is redacted now, but will be unredacted in, as per ICER policies there. Retention is the other area where reSET-O could influence. Again, we have evidence from the pivotal trial for phase 1, and this was this 80.4% in reSET-O and standard of care of 64.1%. And then we extrapolated that discontinuation curve for the comparator to achieve the 14.5% discontinuation per cycle. And so that is how we modeled discontinuation after the evidence source of 12 weeks. Next slide. Health state utilities, there's a lot on this slide. One thing I want to draw your attention to is that there is this utility bump or a utility improvement for abstaining, so moving from illicit use of opioids to no illicit use of opioids. There's also a utility bump from getting people who are illicitly using opioids on MATs. We're seeing benefits of abstinence and benefits on MAT even in our utility estimates. This off MAT and no illicit use of opioids. So we have this northeast square in the table. That is for individuals who are off MAT and no longer illicitly using opioids. And how we define that is individuals who have essentially been off opioids for 1 year, and then a small percentage of those individuals go onto that slide. And that number is relatively comparable to a health state utility of the general population for this age. Next slide. Our costs of reSET-O, the wholesale acquisition cost is $1,665. Pear Therapeutics did provide us the net price, which was $1,219, and it is the net price that is used in our model and informs all results that I will present. Next slide. Again, our intervention, the reSET-O is a part of that, but then there's also outpatient MAT, both in our intervention arm and in our standard of care. And this included 6 therapist counseling visits over that 12-week period. You can see the unit costs presented there. And of course, there's a cost associated with MAT, and the price that we used was for generic sublingual buprenorphine and naloxone. Next slide. And then there are healthcare utilization costs in addition to reSET-O, in addition to outpatient MAT. Now, before you look at these numbers, please listen, these are per cycle costs. These are not unit costs. So this is the cost over a 4-week period. These are also average costs. So this is over a variety of patients, the average cost per these healthcare utilization categories over a 4-week period. So I know that contrasts a little bit the unit costs that were presented on the slide before, so apologize in advance for any confusion. The big thing I want you to take away from this slide is that getting people on MAT, so moving from off MAT to on MAT, getting people on MAT is associated with cost savings in reduction in hospitalizations and reduction in emergency department visits. And so again, we're seeing benefits of on MAT, not only on the utility side, but also on the cost. Next. Societal costs, we do expand our perspective to a modified societal perspective. And in that, we account for productivity losses in criminal justice and incarceration costs. And again, if you look at our criminal justice and incarceration costs, there are fewer costs for individuals who are on MAT as compared to off MAT. Next slide. So let's get into the results. The next slide shows our discounted model outcomes for our base case. And just a reminder, our base case is comparing reSET-O to standard of care, where standard of care is outpatient MAT that includes pharmacological counseling and, pharmacological treatments and counseling. And this is a 5-year time horizon. The first column is reSET-O download cost. You'll see this is that net price I just talked about, the $1,219. The total health system costs include that reSET-O download cost. So this is total, inclusive of the download cost. And if you look at this bottom row here, the incremental cost is $774. And that's because it's not higher than $1,219. So there are, because of those cost offsets associated with healthcare utilization. And then there's life years. The life years are very, very small. The only reason we factored into mortality is based on a standardized mortality ratio associated with illicit use of opioids. And because there was only a 10-day difference in phase 1, there's not too big of a difference here on life years. QALYs, we have incremental QALYs of 0.006. This is driven by this difference in retention and therefore difference in utilities. EVLYGs are nearly identical to QALYs, again, because there's not much life extension expected with Reset-O. And so I'm just going to focus on QALYs for the rest of the talk, knowing that EVLYGs are quite similar to QALYs. Our full report has EVLYGs for every analysis. The last column I want to focus on is on MAT years. This is 0.54 in Reset-O as compared to 0.46 in standard of care, with an incremental difference of 0.08 years, which equates to about 1 month of additional time on MAT. Before we progress to the next slide, look at these numbers. These total health system costs are pretty small, and the total QALYs are also very, very small, 0.006 here. So we're living in this world of small costs, small effect. So when you make changes to either of those, the ICER can be quite sensitive. Next slide. All right, so incremental cost effectiveness ratios, focusing here on the incremental cost per QALY gained, is 121,500. Next slide. The one-way sensitivity analysis, this is the most important slide that I'm going to talk about. So if you hear economists and you zone out, focus in right now. This is a tornado diagram. Our vertical axis is our ICER, that 121,500. And then our bars show uncertainty based on each input that's informing our model. As you can see, this top bar, Reset-O effect on MAT retention, is very, very influential on our results. And what values do we choose to vary this by? We choose it by the bounds in our 95% confidence interval in the pivotal trials. These are all very plausible values. And you can see when we use the lower bound of the confidence interval, we have incremental cost effectiveness ratios of near 500,000 for QALY gained. Next slide. Here's a probabilistic sensitivity analysis results. Big thing to take away, about 75% of probability that it's cost effective greater than 100,000 per QALY. I do want to note here, this captures input uncertainty. It doesn't capture structural uncertainty. So if there are different assumptions or different structure, that uncertainty is not captured here. Next slide. Here's our trial time horizon. Focus on the third shaded row, the incremental under the time horizon 12 weeks row. This compares our 12-week results to our 5-year results. So our incremental Reset-O download cost is the same, $1,219. The total health system costs are a little bit higher in the 12 weeks because we don't have extended retention beyond 12 weeks. And therefore you don't get those cost offsets beyond that. QALYs, again, are slightly lower because we don't have extended retention after that 12 weeks, so you don't get that long-term utility bump. On MAT years is 0.02. So when you're comparing that, sorry, I'm just getting some comments, so I want chat, so I'm staying on top of those. When you're comparing those to the bottom row here, there's really not too big of differences, but you'll see drastic differences in the cost effectiveness findings. And that's because we're living in this small number world. And so if you change costs by a little bit or QALYs by a little bit, your incremental cost effectiveness ratios change quite drastically. But the one thing I want you to take away from this slide, and then we'll move on, is that you're on MAT years. The difference between our 12-week and our 5-year extrapolated time horizon is 0.06 MAT years, which is approximately 3 weeks. Next slide. And again, here is our trial time horizon incremental cost effectiveness ratios. Now they are upwards of 500,000 per QALY gained, much different than what we saw before. Next slide. I might skip these slides because I know we need to save up on time. I'll just talk through them as we progress. The societal perspective, because now the numerator, the costs are even smaller than the 774 in the base case. The incremental cost effectiveness ratio on the next slide is more favorable than our base case at 88,000. Next slide. Limitations, Dr. Tice already walked through her first bullet beautifully. The lack of comparative evidence on our outcomes after an individual has stopped Reset-O is extremely limited. The comparator arm in the pivotal trial for Reset-O was not reflective of standard of care, and so we had to make adjustments there. And related to that, the impact of contingency management, in addition to MAT, is inconsistent in the literature, especially for the opioid population. Next slide. Very thankful for all the comments we received. The manufacturer provided us the net price, which we updated our model. The provider interactions with the platform. we now occur within the counseling session, not as incremental as we first assumed. That was incorrect. We updated utility values. We did not this claims-based analysis of healthcare utilization that Dr. Tice walked us through, and that was primarily due to the concerns with regression to the mean, and not this paper did not publish how these individuals were chosen. And my next and last slide, I believe, is the conclusions. Reset-O is within commonly used thresholds if a significant impact on MAT retention is extended after the use of Reset-O. Now, if individuals immediately revert to outcomes characteristic of standard of care after Reset-O use in this period after 12 weeks that we don't know, then the findings from the 12-week time horizon are more indicative of the cost effectiveness, suggesting Reset-O is not cost effective. Okay, and so if you don't buy that additional 3 weeks of MAT retention that occurs after 12 weeks, you might want to focus more on the 12-week time horizon. Which leads us to conclude that clinical evidence on MAT retention and abstinence after one's use of Reset-O is essential to reduce the uncertainty in the cost effectiveness findings. Next. Eric, what do you think? Do we have time for questions? I'm going to get caught up on chat.
No, you're good. So we're gonna move into the public comment period now, Melanie. It was an excellent presentation. So on behalf of the CEPAC, let me extend our appreciation for a very clear presentation. We've all had the opportunity to review these materials in advance, and I know you'll be with us for the remainder of the day. So I'm sure that questions and comments will surface. I appreciate my colleagues sending me a few of those questions in the chat box, and we'll surface those during the day, or maybe